Mulenga, a 12-year-old boy, has several mitral incompetencies secondary to an attack of rheumatic fever, which he had 3 months ago. Of the following, which is the best way to manage Mulenga? Monthly benzathine penicillin prophylaxis should be given up to the age of 21. Captopril has no role in the treatment of this condition if he develops congestive cardiac failure. Monthly benzathine penicillin prophylaxis should be given for life. Surgery is contraindicated. Any thought on this one? Anyone that has something to add? This patient has rheumatic fever. So what is the best management for them? Okay. Why would you go for that one, doc? Okay. Thank you so much. Uh, is there anyone that has got another thought? Okay. So monthly benzathine prophylaxis for life. Okay, that's from our good doc. Is there any other thought? So we have got two so far. Any other thought? Let's feel free to contribute. The more the ideas, the better. Okay. So as far as I remember, when we are treating rheumatic fever, the drug of choice is really penicillin. And this was a class in internal medicine that said when you are giving the drug, you give it for 5 years or up to the age of 21. Any one of them that you attend first. If you give for 5 years, but if someone will be attending the 21 years soon, you give up to 21 years. That's one thing that was mentioned from the tutorial. For 5 years or up to 21 years. It's a drug of choice. Hmm. So I feel we can go best for A. Monthly benzathine penicillin should be given up to the age of 21, or it can be given up to 10 years for the treatment of rheumatic fever. Yeah. And then number two is saying, which is, y- yes, please, doc.
for in 2 years or up to the age of 40, whichever is long between the two is what we say. This means that the patient has got the age of 45 years old and they have got rheumatic fever with a valvular heart lesion and they're presenting with symptoms. Because they're 45, they're almost to 40, so give them for 10 years, meaning you're going to up to 85. But if let's say they are 29, you give them up to 40 years. So it shows whichever is longer, whether the 10 years or up to the 40 years. And then the second one is someone who has got rheumatic heart fever with a valvular heart lesion but doesn't have symptoms. So for such a case, they should go for 10 years or up to the age of 21, depending on which one is longer. And the third one is somebody who has got rheumatic fever but doesn't have the valvular heart lesion. In that case, it's give for 5 years or up to the age of 21. That's what I remember about the medication for rheumatic heart.
Okay, thank you so much. So in this case, which one would you go for? Doc, on our question here, what are you going to go for?
I'll go for A.
Okay, thank you so much. But let's get to take note of what the good doc mentioned about the symptoms, and then because he's specifically in a pediatric patient, from the sources I've read is for a pediatric patient, you're actually going to treat them for either 10 years or for until the age of 21. But the one tutorial in internal medicine, they mentioned up to 5 years or up to the age of 21. But this is a pediatric patient, we can take it like that. Yeah. So number 2 is saying, which is the most correct ECG finding in the condition given? ECG findings of right ventricular hypertrophy are right axis deviation and tau R wave in V1 and V2 and S wave in V5 and V6. Features of Epstein anomaly on the ECG are the same as those of right ventricular hypertrophy. ECG finding of pulmonary hypertension are the same as those of tetralogy of Fallot. Left ventricular hypertrophy is always associated with left axis deviation. Mitral stenosis only presents with tau P waves on the ECG. How about this one? Any thought from anyone? Any thought? All right. On an ECG, some things that we have to be aware, like when you're talking about the deviation of the axis, whether it's the left axis deviation or right axis deviation. For right, for the one where you have got right ventricular hypertrophy, this one is going to be more associated with right axis deviation. So maybe we can just think of right axis deviation with right ventricular hypertrophy. Yeah. So when the right atrium enlarges, there is this strain that will be on the right atrium, because we know that the right atrium, that's the one that is going to be receiving blood from the rest of the body. So there's actually a strain on the right atrium. So associated with the deviation on the ECG to the right. With the other options, B saying Epstein, it's saying uh, Features of Epstein anomaly on the ECG are the same as those of right ventricular hypertrophy. Now, Epstein anomaly is going to have some features of right atrial enlargement, but the ECG findings are not really going to be the same. For example, in Epstein anomaly, when you look at the QRS complex, they are going to be also talking about it. It's depressed, it becomes shorter. That is the QRS complex. So even if some features are really similar with where you have also some features of right atrial hypertrophy, actually right ventricular hypertrophy, not all the features are going to be the same. Yeah. Epstein anomaly is going to have, for example, a short PRI interval. Normally, the PRI interval is supposed to be the same as the QRS complex, but then this one becomes shorter. C is saying the ECG findings of pulmonary hypertension are the same as those of tetralogy of Fallot. Again, for this option, not really correct. Again, there might be some features, for example, uh, in pulmonary hypertension, because you have got a high pressure in the pulmonary artery. It means that the right side of the heart is going to be trying by all means to push blood against this high pressure, and so the right side of the heart is going to become hypertrophied. So in actually pulmonary hypertension, you expect to have right axis deviation. Remember, okay, there's going to be right axis deviation because there is a right ventricular hypertrophy. Now, tetralogy of Fallot may also show some right axis deviation, but also besides that, you are going to have some other blocks, the bundle blocks. In other words, the features are not all the same, even when there are some similarities. And then the option D is saying ECG findings, left ventricular hypertrophy is always associated with left axis deviation. So for that one, it's not always. Actually, questions that say always, just know that it's wrong. Sometimes in uh, ventricular hypertrophy, you can have left axis deviation, but not always. Some patients with left ventricular hypertrophy can actually have a normal axis, or sometimes you can be deviated to the right. And then the last option is saying mitral stenosis only presents with tau P waves on the ECG. Now, that is not true. When you have got these P waves that are broad, so when you are looking at the P waves, they can be either long or broad. I think there are terms they use known as P mitrale and P pulmonale. For the P mitrale, it means that the P wave is actually broad. Mitrale, it is long. So when you have got broad P waves, this is a finding in left atrial enlargement. And then the P waves, when they are taller, that is P pulmonale, it means that that will be right atrial enlargement. So please, let's get it. When the P waves are long, okay, long, that is P pulmonale, and it means that the right atrium has enlarged. But when the P waves are wide, that is P mitrale. Just try to, I want to write something so maybe it can help us to remember. Let me just put my board. Okay, hope you can get me. So When you look at M, look at it. So think of it, M is going more in this direction, right? That is a P mitrale, where you have got a wide P wave. And then for the pulmonary, think of a P, a long P. So it is more longer in this way, a tall P wave. So those are the two we need to consider. So for P pulmonale, it is a right side. Look at this. The P is pointing which direction? This come ahead of the P is pointing towards the right. So it is a right. That is just to help us remember. That is right atrium. We all of them we consider just the atrium. So right atrial enlargement. For the M, the mitrale, which is broad, it is a left atrial enlargement. I hope that can help us remember. Okay. Number three, an 18-month-old girl presented with a 3-day history of diarrhea. Oh, there's a question. Okay. A 19-month-old girl presented with a 3-day history of diarrhea, which became bloody stained. She had not been reported to have passed urine during the previous 24-hour period. On exam, she had mild generalized edema and her BP is 120 over 90. Investigations reveal, okay, I'm coming back to question 2. So investigations reveal sodium 128, potassium 6, and then urea 40. HB is 8, platelets 40. Blood film reveals microangiopathic hemolytic anemia. So let's just go back to this one. So here the answer is A. ECG finding of right ventricular hypertrophy. Yeah. For E, saying mitral stenosis only presents with top. So this one E is not true, as we've explained. So ECG finding in right ventricular hypertrophy are right axis deviation, tau R wave, V1 and such. But at least remember the right ventricular hypertrophy with the right axis deviation. Of course, the R wave is also tau. And then you have got the deep S waves. Like the S wave, we know how it goes on the PRIS complex. You have got this. This is Q R S. The S wave is a bit deeper in right ventricular hypertrophy. Okay, so here is our this is our patient here who has got blood diarrhea, which is blood stained, and then she has not been reported to pass urine. So no urine in the previous 24 hours, but has generalized edema. The BP is 120 over 90. It's like that's like normal. Okay. Investigation review sodium is 128, and we know the that is a bit low. Potassium, it is supposed to be 6.2. If it's 6.2, it means that it's high. And then urea 40, HB is 8, platelets 40. Blood film reveals microangiopathic hemolytic anemia. What is the most likely diagnosis? Meningo meningococemia, ferrous sulfate poisoning, hemolytic uremic syndrome, autoimmune disease, botulism. What do we think about this one? What do you think is the diagnosis for these features given? Anyone?
C.
Okay, C. Why do we pick C? Why do you pick
The
C?
reason why I think C. Okay, so the reason why I think it's C is because in this case the patient is presenting the typical type of hemolytic uremic syndrome. One that got a 3 day history of diarrhea. We know that the HES is caused by fecal-like toxin, which affects the intestine, that causes diarrhea. And then they also have got microangiopathic hemolytic anemia, which is one of the features of the trial. Then apart from that, we're being told that they haven't passed during the past 24 hours. Something that can be indicative of acute renal failure, which is also part of the trial. And lastly, also the comorbidity. So that's the reason why I think
All right. Thank you so much, Doc, for that one. Good explanation. Yeah, so we have got a classical triad of hemolytic uremic syndrome. Hemolytic anemia, as we can see, the HB is low. Thrombocytopenia with a low platelet. And then we have got acute kidney injury. In AKI, the features of AKI, we did even discuss in the previous class when we were talking about Peads. You have got electrolyte imbalance, you have got failure to pass urine, like oliguria or even anuria. And so you can also have things like hyperkalemia, even from the question, because electrolyte imbalance, you can see from the question there's hyperkalemia and hyponatremia. All those are features, and the generalized edema. Those are features of acute kidney injury. Anuria, high urea, which is 40, generalized edema, and then you have got things like hyperkalemia, hyponatremia. Okay, so those are the features. But then we have got two conditions I want us to differentiate a bit. Uh, Hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. Anyone who can help us differentiate these two? Just any difference that you know. Hemolytic uremic syndrome and thrombotic thrombocytopenic purpura.
so in thrombotic and protein protein, I want to how things are being present to go the same time. And then in this case, when we have the best is B is Adam Tito. The people with the boys are supposed to be going to have both protein, um, then ammonia as well. Let me not post them, but they're supposed to fight. But ideally, I think that when it comes to this efficacy, you're going to have Adam as the best team that is involved with um, um, development of the yeah.
Okay. Thank you so much, Doc. Yeah. So just an addition to what the doc has said, when you look at these two conditions, both of them are actually disorders which are known as thrombotic microangiopathies. They all lead to the breakdown of the blood cells in the small vessels. But then hemolytic uremic syndrome is more common in children, while thrombotic thrombocytopenic purpura is more common in adults. And when you look at the cause for hemolytic uremic syndrome, it's actually E. coli, the sugar toxin producing E. coli. We know we have got 5 strains of E. coli, isn't it? And that's why you can see even bloody diarrhea in this question, because for hemolytic uremic syndrome, this sugar producing guy causes the bloody diarrhea. And please, let's get to review the 5. We have got, maybe let's mention them because it's something we can mention. The 5 strains of E. coli. Anyone who can start with one? The E. coli, the 5. Number 1?
And the hemorrhagic,
Yeah, enterohemorrhagic. Thank you so much. Any other from anyone? Any other? So we have got enterohemorrhagic. Not even one, guys. I know it's somewhere on the tongue of someone. Please feel free to open your mic. Sorry, the enterotoxigenic. Number three, the enteroinvasive. Yes. Number four. Okay, which has been mentioned. So we also have pathogenic and we have aggregative, isn't it? Aggregative or aggregative? Supposed to be aggregative. Yeah. So two of them cause uh, watery diarrhea, and then three will cause bloody diarrhea. But when you come to thrombotic thrombocytopenic purpura, the problem is that it's not with the E. coli, but it's a deficiency of an enzyme, which is Adam TS13. So that's a problem there. So likely even the diarrhea that we are seeing here, we might not be able to see it. Yeah. And then the prominent features in HUS, you are going to have kidney injury. That's the most prominent feature. But then in TTP, you are going to have neurological symptoms like confusion, seizures, and such. And then another typical, when it comes to other features that you are going to look at for the two conditions, okay, we have already mentioned the age and then the types of what causes the problem. I think those are the big things. For the HUS, there is a triad which we've mentioned: hemolytic and microangiopathic hemolytic anemia, thrombocytopenia, and AKI. And then often you are going to have bloody diarrhea from the history. That's also important because of the pathogen. But then for for TTP, you have got a pentad where you have got a fever, anemia, thrombocytopenia, renal dysfunction, and then neurological abnormalities. Yeah, so those are the features. So they use a mnemonic fatty RN. The F is fever, A is anemia, T is thrombocytopenia, and then the R is renal dysfunction, and then neurological abnormalities. Okay, so that's a review of those problems. Number four is saying which of the following, which in the which is the most in the most true. No, it's not supposed to be in. Which is the most true statement? Which is the most true statement regarding sickle cell disease? Splenic sequestration may occur as early as 5 weeks of age. Dactylitis is more commoner in older children. Acute chest syndrome is common in non-fetal. Epstein-Barr virus infection is the most common cause of aplastic crisis. Blood transfusion is only indicated in severe anemia. Anyone who can help with this one? We want the most true statement. Which one? Okay, one in severe anemia. We all support. Do we all support D, or there's someone that has got another thought? And this one says only indicated in severe anemia. And actually, question options to do with only, we need to be a bit of. And yes, doc. Okay, why? Okay. If we get to look at what cause what you can do, like What will make someone who has got sickle cell anemia to be transfused? Besides the severe anemia, and if we are classifying it as severe, then we are looking at really the HB. There are also some other features that we are going to be able to look at. All right, just a second. Okay, sorry, my good doctors. It's just an emergency that came up on the phone. So I was saying that besides us looking at the HB, when to consider blood transfusion, we can look at other features. For example, if the patient has presented with, yeah, if the patient has presented, let's say, with acute chest syndrome, we can actually consider transfusing that patient, even if the HB looks fine. Or maybe if someone who has got other complications of hemolytic anemia, for example, they are presenting with a stroke and you want to prevent that. So you can as well get to transfuse them. And let's say, for example, for whatever reason, you're supposed to treat to operate on this patient, but they don't have severe anemia. So those can all be indications of the transfusion besides just the severe anemia itself. And the tricky thing is that the option says only, which is going to be a trap. Yeah. So for me, the best one we can pick here is splenic sequestration, which may occur as early as 5 weeks of age. So just as early as that, we can be able to notice splenic sequestration in a patient that has got uh, sickle cell disease. What is really splenic sequestration? Anyone that can help us to define it? What is splenic sequestration in hemolytic? I mean, in sickle cell.
When by tapping a red blood cell in the skin, whereby let's say by vasopressin that is called by the second red blood cell, for blood a vessel which is more like what is called the skin, so blood will be more like tap. The cells we tap in the skin causing it to become bigger and causing because of anemia and other stuff.
Yeah, yeah. Thank you so much, Doc. It's sequestration where the red cells are just trapped in the spleen. And then the spleen is now doing more work to try to break them down. So it enlarges and that results in severe anemia. Yeah, by 5 weeks of age, you can actually get to see this feature of uh, hemolytic, I mean in sickle cell. For dactylitis is more common in older children. Really not true. Acute chest syndrome is common in non-fetal. This is a bad condition. Epstein-Barr virus infection is the most common cause of aplastic crisis. Okay, that's a lie. Blood transfusion. Okay, now let's Let's talk about some organisms. There are some organisms that are important in patients that have got sickle cell disease that we have to be aware of. For example, salmonella is one possible problem that comes in, and this is going to cause the many other problems that can result. But for aplastic crisis, the big problem here is it's not caused by Epstein-Barr virus, but there's another virus that causes it. Which virus is that one?
That's the problem with
Yeah, thank you so much. The Pavo B virus. How about salmonella? What problem, what complication of sickle cell disease does it cause?
hemolysis, hemolysis.
Yeah, thank you so much.
Hemolysis.
Yeah, you have got this involvement of the bone. Okay, number five is saying osteomyelite. Number five, yes, doc.
From the book that I was using to study sickle anemia, so they say that when it comes to sickle anemia, it talks about like in a child or in a people in an infant rather, because of will start happening after 12 months, 12 to 6 months somewhere there. Because during the early period of infancy, you're going to have things like you're going to have high levels of the total hemoglobin, which is produced when you are young, and then it's going to end somewhere in the 6 to 8 months. So from what I understood from that, probably before us, you can't really see any because of because but after 5 to 6 months, you're able to see because of sickle anemia. So I'm confused, but let me talk to come to me your understanding now.
Yeah, it's actually true, doc. With the features, they'll start so the manifestation itself is it starting somewhere about, is it fifth month? That's why we can't make a diagnosis before then, isn't it? In sickle cell, like if someone has got sickle cell, you can't make a diagnosis when these children are so young, like below should be 5 months until then. But then the problem with the kidney can start happening so early, though you can't see really the manifestation at that particular time. The sequestration itself is happening early, but then the features you start seeing them later on, somewhere 5 months. I don't know if that's okay.
All right, but thank you.
Oh, sure, doc. Thank you so much. Number five is saying a 5-year-old child has been brought to hospital with facial swelling and respiratory difficulty of sudden onset. What would be your immediate response? Okay. 5-year-old has been brought to the hospital with facial swelling, respiratory difficulty, and sudden onset. What would be your immediate response? Give a bolus of IV hydrocortisone 4 milligrams per kg. Give zero point 0.5 mils of 1 to 1000 adrenaline. Administer 100% oxygen and alert the anesthetic team. Administer IV chlorpheniramine 0.2 milligrams per kg. Put the child in head lowered position. What do we think? What are we gonna do for this patient? This patient has come in with a swelling and then difficulties in breathing. What are we gonna do for them? Anyone? Remember when we are doing the assessment, the ABCs? When you find that there's actually mostly when you find a problem with the A and the B, what you want to do is to give oxygen. Okay, that's what we want to do. So for me, that was what I could actually pick, because with medical emergencies, when you are assessing the quick assessment, you want to pay attention. Is this patient breathing? And there's actually a problem with breathing, and how you get to help counter that is by giving the oxygen. But then I don't know if there's someone that has got a different thought. Anyone with a different thought? This these things we should be able to debate through so that we can be able to have more knowledge.
I was thinking that what if a person schooling has something to do with respiratory problems? Why do you want to give oxygen before you do any maybe if there are children or anything if there's any children? Why can't you go with maybe
Yeah.
open up the air or something?
Okay. So in that case, on our management here, what would we what which one would we go for?
I'm thinking giving oxygen, even if you give oxygen, the person has an children, won't make a difference.
Yeah, it will still be the problem because it's still there, isn't it? Yeah.
Then this way, does it mean that you are trying to open up the airway or maybe I'm getting it wrong? This head, put the child in a head lowered position.
So a head lowered position. Okay. What do others think on the E? Put a child in a head lowered position.
Can I say something?
Yes,
I
doc,
think
please.
on E, we put the child in the lower position. In this case, this the child I would also say it's possible that maybe you also have think of maybe also would do not maybe no dinner, but also no figure rather. Maybe even before I would dinner. It's possible. So maybe putting the child in the lower position, maybe the ground is flat. That will be the best thing to do. Well, I think giving us I think it's the best thing for this child. For now, I've got no support, I've got no intervention. I think it's hospital. Well, I don't know if that's so, but I think it's hospital.
Okay.
And my
Uh,
question is that if you give oxygen, where you have said that maybe that the respiratory edema, how is oxygen going to help?
okay. Yeah. Actually, when we look at this question properly again, the problem is because when you're assessing when you are trying to assess the airway, you're supposed to do away with the obstruction. That's the first thing. Do away with the obstruction. And this question actually states that you have got this guy. This difficulty in breathing is of sudden onset. So, what would really cause a facial swelling with respiratory distress that is of sudden onset? So, most likely, this can be an allergy. And for the first line treatment for allergic reactions is actually the adrenaline. When you give this adrenaline, it is going to help with reversing, because in this case, what is causing, if it is an allergic reaction, really, because it's quick in onset, what is causing the difficulties in breathing is actually the obstruction. So if you give the adrenaline in this case, it's going to be able to reverse that obstruction, and then we can now be able to give also the child the oxygen that we'd want to give. Yeah, I get what the doc is saying, because as long as we still have the obstruction, even when we are giving oxygen, we are barely helping this patient. But first thing first, we remove the offending agent that is causing the obstruction, and then we can provide the oxygen later on. I think oxygen should be able to come later on in this case. I don't know if we agree, or maybe this we can debate a bit more.
Yeah, the allergic reaction doesn't make any sense.
Yeah, so the best thing we will do first start with the adrenaline, which is the epinephrine. So epinephrine is the first line when it comes to the treatment or the management of anaphylaxis or these allergic reactions. And then we can do anything else that we want to do thereafter. Number six is saying the following are true concerning the management of bacterial meningitis in childhood. Serum sodium of 120 ml per liter on the third day of treatment is likely due to excess renal loss of sodium, Crystalline, penicillin, and chloramphenicol are drugs of choice in 2-month-old infant. Gentamicin can cross a blood-brain barrier as efficiently as heparin. Steroids are never used in the treatment of meningitis. If has been preceding antibiotic therapy and the CSF reaction is totally lymphocytic, the most likely diagnosis is TB meningitis. What do we think on this one? Any thought on this one? Bacterial management of bacterial meningitis.
I don't know how is so
E. If there has been preceding antibiotic therapy and the CSF reaction is totally lymphocytic, most likely the diagnosis is TB meningitis. Okay. Would you want to say something about it, Doc?
thinking because when it comes to other things when it comes to this meningitis, it is one of the identical as well. And I think when it comes to mosquito market, meningitis, basically it's a bit similar to how we treat bacteria, but of course we have a specific antibiotic which is around to treat TB. But I think if you use antibiotics, might show a bit of improvement. But in order to treat treat this specific, you're supposed to use because I'm thinking, I don't feel like it is cost, but if you any other option, I think I'll also go for that. But I don't feel it's my option right now. I don't know what I'm going to
Which one, B or E?
do.
Oh, okay. Yeah, when we look at meningitis, like the bacterial meningitis itself is going to have an elevation of the white cells between 2000 to 5000, specifically the neutrophils. Now, uh, TB is also a bacteria. But one special thing about TB is that when you look at the cells that are elevated, it's actually not the neutrophils but the lymphocytes. So that is what will differentiate. Besides looking at the cells, when you also look at like the a test tube of CSF, you are going to see this cobweb appearance. So that's how we diagnose TB, like looking at it. So I do agree with E, where we have got if there has been preceding antibiotic therapy and CSF reaction is totally lymphocytic, the most likely diagnosis will be TB, meningitis. Yeah. When we look at the other options, serum sodium of 120 on the third day of treatment is likely due to excess renal loss. This one, 120 means that you have got actually hyponatremia because the normal is 135 to 145. So hyponatremia in meningitis, specifically bacterial meningitis, is really not because of renal loss, but it's because of the syndrome of inappropriate ADH secretion. Yeah. So we know that in syndrome of inappropriate ADH secretion, there is a lot of secretion of ADH, and that what that causes is that there's going to be reabsorption of water, and so the effect is that there's going to be dilution or hyponatremia. Not really that you are losing the sodium, but it's just diluted. For B, which is saying crystalline, penicillin and chloramphenicol are the drugs of choice. Actually, in children, the drug of choice is going to be ampicillin. You can also add a cephalosporin or an aminoglycoside. And then gentamicin can cross the blood-brain barrier as efficiently as Septrin, which is the trimethoprim and sulfamethoxazole. That one is not true because gentamicin actually has got poor CSF4 penetration. Yeah. So A would be a very good option. And then seven, in acute post streptococcal glomerulonephritis, long-term prophylaxis indicated to prevent recurrence. There is usually a good response to a short course of high-dose prednisolone. Most cases recover completely. There is no polyuria during the recovery phase. Albumin infusion is often indicated for peripheral edema. Which one do we think for this one? In acute post-streptococcal glomerulonephritis. Any thought on this one? Any thought, doctors? Okay. So when we look at option A, it's saying the long-term prophylaxis is indicated to prevent recurrence. Now, recurrence in the acute condition of post-streptococcal, because how this infection comes, like the glomerulonephritis after a strep infection, it's either when someone has got pharyngitis or they have got a skin infection. That is how they are going to end up with this disease going to the kidney, and the recurrence is really really rare. Okay, and then B saying there is usually, so because the recurrence is rare, even the long-term prophylaxis is not necessary. Okay, and then B saying there is usually good response to short course of high dose prednisolone. Now steroids are going to be used in this condition. Yeah. But then when you are managing the condition, because what happens in post-streptococcal glomerulonephritis, what's the problem? The problem is actually you have got this antigen antibody complex that has been formed and then it is being deposited into the kidney, and that is what is causing the problem. Okay, there is this reaction by the body to the antigens of the bacteria. But when it comes to management, the main management of this condition is actually going to be supportive, like fluids, BP, and then treating the disease itself. Okay, other than concentrating on this short course of high prednisolone, high dose. And then for C, most cases they recover completely, and that's true for acute streptococcal glomerulonephritis. They actually recover completely. Yeah, and then the kidney will come back to normal. They'll be able to function well. E is saying albumin infusion is often indicated for peripheral edema. Now, peripheral edema is going to be managed with the restricting fluids, not really you giving the albumin in this case. Okay, unless if you know, because why we sometimes get edema is because you have got lead to albumin, because albumin actually keeps fluid in the vessels. But in this case, unless you know that albumin is really low, that's when you want to give albumin, because that is going to be a cause for the edema. But mostly you want to prevent the edema in this condition by restricting fluid intake. Number 8 is saying, what is the most appropriate way to treat a neonate with congenital syphilis and evidence of CNS involvement? Treat with IV chloramphenicol for 14 days, IV crystalline penicillin for 21 days, IV crystalline penicillin for 14 days, Give benzathine penicillin weekly for 3 weeks. Treat with IV gentamicin for 14 days. So congenital Louis, how can we treat it?
let's focus on number 7.
So number 7, most cases recover completely.
Because
Sure, doc. What do we think about this one? How can we treat congenital Louis?
we're supposed to use predictable. Because you can use predictable. Supposed to be on none. Because, yeah, just for none. So, just for none to fix it somehow.
Okay, yeah. So yeah, I think I agree with you, doc. So we treat with the IV crystalline penicillin. Or you said benzathine.
Yes, predictable. I don't know what is supposed to be on. Because I'm predictable. But try to fix it somehow.
I know of the benzathine penicillin when we are using when for those heart conditions like the rheumatic heart disease. So for this one, I know of the crystalline penicillin. Yeah, but like for the benzathine penicillin. Mm, okay, let's see what others say. What do others say? In case also someone also came across something like that.
Benjamin penicillin is in adult. Only for children is crystal penicillin.
Yeah, so the crystalline penicillin. Yeah. So again, the benzathine we can also use it, but if there is no CNS involvement, that's when we use it. Because for the benzathine penicillin actually doesn't reach therapeutic levels in the CSF. So for this one we can give the crystalline penicillin for 21 days. Number 9 is saying the following are true about ready to use feeds, except it has more composition at F100, that should be than F100. Have improved the community management of malnutrition, is not recommended for children with edema, 2 plus and dermatitis. It is well tolerated by many children. A child on ready to use therapeutic feeds needs take a lot of water. Any thought on this one? Any thought? Okay, there is a.
I think I'll go for C.
Okay. Why do you go for C, doc?
Because when it comes to our community, I just want to go the body in the photo, but when it comes to people, when it comes to using our used to use the method of this. So this is why we control apart from the organization to the people. We're supposed to use our work is supposed to compete with also to think about our sort of the our work. So the price for it on top of that, that means that subtract the cost. And then depending on how severe they are supposed to be, you're supposed to you're supposed to give them either off-handed or our to the our school, it's not taken off-handed. And then some people prefer you to give them our work for some work off-handed. But most people when it comes to successful people, the commercial content, our work has more. And then when it comes to the criteria of continuous action, from the first stage, which is the first 2 days, we're supposed to look at the picture of top of the phone. The first thing we see what we have is the power, then authorities and also the owner. Once the owner is resolving, we're supposed to implement it as a putting the task on the phone store to see if we can go to the next stage, the next step there. So things like internal and authorities, it's not supposed to say when they come to you giving them the job. But if it's resolved, maybe you can consider putting them in the court or a couple of process. Yeah, so those two for me the best answer here. I don't know if that's correct, but it's what I would think. Yeah.
Okay. Okay, let's see. Yeah, is there any other suggestion before besides what the doc has suggested? Any other
I think
thought?
it's fine.
Sorry.
I think it's fine.
Okay. A. It has the same composition as F100. Why do you go for A, doc?
It's saying except
Yeah, we want an
uh,
exception.
you want the first statement. So I think ITF does not have the same composition as F1.
Yeah. So it doesn't have the same composition. Hmm. That's
But
why
we can cross check.
yes, we want an exception. Yeah. That's why we'll start giving these patients, is it F75? After we notice that some changes happening, RUTF is an appetite test, isn't it? We start giving them. If they can feed a certain amount, is it two-thirds? And then we can now start giving them the F100. Why are we even changing like that? Is because of these differences in composition. At what age is the first dose of rotavirus vaccine given in Zambia? 6 months, 6 weeks, 1 year, 2 months at birth.
Excuse me, sir.
Yes, doc.
Yes, which one will you take in option C?
Option C. It is not recommended for children with edema 2 plus dermatitis and with edema 2 plus and dermatitis. Mm. So for children that have got dermatitis and the edema, when we give them these ready to use therapeutic use, they might have complications that require inpatient care because this edema already that they have and also the severe dermatitis, because this ready to use therapeutic fees, these are things that you can actually give to a mother and then they're at home. But how about if the child ends up developing complications that they can't really manage at home because of this ready to use therapeutic feeds? So that would mean it's going to be a problem. Yeah. So that's the only thing that I think of. I don't know if another person has got another thought.
Let me just add on to what you said, but from what we have said by the doctor and also, when it comes to you using the child, you're supposed to assess what they have. For things like when you have edema who's not resolving, who's not gone, if you see if edema who's just like happening with food, and then for second the leg and the feet, that means it's not resolving. And also the maternity is just disputed with the go and then with the one and communicate. So I think when you just see edema which is not resolving or which is not which is failing on further, and also the maternity, don't give them now. Well, it's IoT or handed. And that's our support. In just normal situations, don't give them that because the point to prevent another prevent things like adaptation vaccine. So your body is going to, it's already adapted to the lower energy limit. But here we're going to be giving those 79 hours. Later on when there is no, when the body gets adapted to taking those products, so after about 2 days, 2 to 4 days, we're supposed to give them water culture to see if they're able to tolerate other foods. So if you're having things like this, that means you're not having enough protein in their body. Then so don't overload their body because they might be a severe reaction. Yeah.
Yeah, thank you so much, Doc. Another thing that I've seen is that for patients that already have complications like edema and dermatitis, before you can give them ready to use the therapeutic feed because it's supposed to be treated as inpatients because they already have these complications. So you first need to stabilize them before you can start giving them the ready to use therapeutic feeds. Yeah. So at which age do we give the first dose of rota vaccine in Zambia? So we give it at 6 weeks, and then repeats 4 weeks later, isn't it?